Okay, so this talk is about endoscopic spine surgery, how it started and where we're at now. Okay, these are my disclosures. I do hold a consultancy with Joymax, and recently I've been working overseas. Right, so why endoscopy? Well, if we go back to the early years, it really dates back to when people first started looking at the disc by percutaneous nucleotomy. And for a short period of time, I remember automated percutaneous discectomy was very popular. And people tried to take the inside out of the disc in the hope that any disc prolapse would then be resorbed back into the center of the disc. Things changed really in 1983 when Cambin described his triangle, and I'll talk about that just in a minute. In 1999, Knight described opening the foramen using a laser. And things really took off at that stage with Young and his inside-out technique. And this again was working on the premise that you started an inside the disc and kind of pulled the prolapse back towards yourself. This seemed slightly irrational, and Thomas Hoogland in 2003 suggested we should do it from the outside inwards. And I started using the endoscope in Edinburgh in 2005. Since then, we've developed and moved on in many ways. So we started cervical endoscopy. We started decompression with a variety of different instruments from different companies. And fusion came in 2014. In about 2018, it seemed rational and sensible to start operating the thoracic spine. And more recently, we started with image guidance using sophisticated tools to help us analyze the exact anatomy. So who's important? Well, Cambin is really given the credit for bringing to the attention the working triangle. And he published this paper in 1984, although he had been playing around with it for a few years before that. Tony Young in Phoenix described his yes technique and working from the inside of the disc outwards, and had very good results from doing that. But as I stated earlier, it isn't the logical way of attacking the disc, as it does create damage to the disc, which may be irretrievable. And just on that thought, discography was initially used to fairly great extent so that we could determine which bit of disc to remove. But if you inject into a disc, it naturally damages the disc substance. So meanwhile, over in Germany, Thomas Hoogland and Wolf Rees got together and brought out the Thomas Hoogland endoscopic spine system, working from the outside of the prolapse and extracting it through cannulated tubes. Quite a lot of credits due to Menno Ippenberg, who started in Wien Hutsen, Holland, really as a maverick. He had incredible problems from the Dutch government in trying to get sanctioned for doing his procedures. And despite appearing on the television and operating on several famous Dutch footballers, this is Ruud Gullit, he really met so much resistance that without doing his private work, his techniques were not accepted by the Dutch community. And I'll come back to that in a minute. Over in Korea, at the Wordle Spine Clinic, Sang-ho Lee, Lou Androsky, and Gun Choi were working feverishly away. And by the late 2000s, we're operating in up to 1,000 cases a year. So a great credit gave to them, and the publications started to come out from that center. How far have we come? Well, it's interesting to look back. I wrote the Cochrane Review of Surgical Interventions for Lumbar Disc Prolapse back in 1999. And at that time, the only operations were open discectomy and microdiscectomy. And all the literature said was that microdiscectomy gave comparable results to open discectomy. The interesting thing, perhaps, was chymopapine, which had about a 70% success rate. So about 30% of the patients came back and required surgery afterwards. But chymopapine, actually, as a treatment at that time, was quite useful, particularly in adolescents. It was my contention that we needed evidence to support endoscopic spine surgery, and this would mean that we needed a randomized controlled trial. So in Edinburgh, we started looking at the transforaminal approach, and I wanted to include all patients at L4 and L5 and also at L5S1. And for those of you who don't operate in the lateral position, the secret to getting to the L5S1 disc is to break the table in the correct position, and that will push the pelvis away from you. The advantages are that the dura falls down and the patient can, under analgesics and sedation, they can chat to you during the procedure. It's much easier in many ways than doing these patients in the prone position, but it does take a slightly different approach. So here's the Edinburgh randomized trial comparing endoscopic discectomy and microdiscectomy. It took a long time to gather the patients together, but we ended up with 140 over a 2-year period. And the interesting, the idea behind the trial was to prove to my hospital that endoscopic discectomy had equivalent outcomes to microdiscectomy. And that indeed we did do, with all outcomes being similar, except for one. And the interesting one was that at 2 years, the amount of leg pain that the patients were suffering was less in the endoscopic group. Both treatments were cost effective and miles below the generally accepted $60,000 per quality gain, which you would expect from a surgical procedure. Complications, again, we wanted to look at, and these were my own complications in the right-hand column, compared with complications that we established from the literature. And what I'd done with my registrar, Mr. Ning, we'd looked at all the trials that we could find on lumbar disc surgery to see the instance of nerve root injury, dural tear, secondary operations, bladder paralysis, and recurrent disc prolapse, and compared this data, which we published in Spine, to those which I'd got on my first 1,500 endoscopic procedures. And the interesting thing is that the incidence of nerve root injury was significantly less than that reported, as was dural tear. And I'll come back to dural tear in a minute or two. The secondary surgery was also much lower, but there is an instance of recurrent disc prolapse, and we have to accept that. The problem actually in the randomized trial was that once you get to past about 12 months, you never really know if the recurrent disc prolapse is secondary to a new event or to some failure of the surgical procedure. So actually, although we like 2-year follow-up data, 1 year probably is more realistic. There are several other randomized trials that have appeared of different quality and different size. Sebastian Rutten in Germany has produced a couple of quite good trials. There have been small trials from elsewhere, but they all basically show that there are equivalent results between microdiscectomy and endoscopic procedures with similar outcomes and complications. Now let's go back to Holland. The Dutch were intent on proving that endoscopy was no use. So they set up the Dutch study, which was published last year, and were, I suppose, disappointed to find that actually endoscopic surgery was better. They found statistically more favorable results for patients' self-reported leg pain, back pain, and functional status. And also that endoscopic discectomy was more cost-effective from a societal perspective compared with open microdiscectomy for patients with sciatica. So good news for Menno Ippenberg. It's a pity he retired in 2022. Where have we got to since then? Well, there are two, I suppose, useful things which in the terms of the lumbar disc prolapse that have happened. One is to get to those awkward disc prolapses. It sometimes requires a transpedicular approach, and Gunther and Kropp wrote this up from Germany. And also the superior articular process approach, which I know Christoph in Seattle has been a big proponent of. It has to be said with regard to that, I think I was actually doing it accidentally considerably before it was put forward, because when I couldn't get into Cambin's triangle, I used to just go through the articular process anyway. That's just for amusement and by the by. Interlaminar techniques. Well, we all know the limitations. If you are operating in the prone position, getting past the pelvis can be difficult. They're really totally suitable for dorsal stenosis of the canal and disc fragments that are sequestered dorsally to the fecal sac. And the indications and contraindications were written up by Ralph Wagner and Dr. Hefner a couple of years ago. If you haven't seen that paper, it's worth having a look at. What's the evidence? Well, Martin Rutten again produced a trial comparing lateral recess stenosis with an endoscopic approach against conventional microsurgical techniques, and again found excellent results in the endoscopic group. Most of the trials actually don't relate to a comparison between interlaminar approaches and any form of microdiscectomy or open surgery. But there are several now which compare transforaminal approaches versus interlaminar approaches. And actually, I think it's horses for courses. I don't think it's a fair comparison, because what we're really trying to do is to use the correct approach for the correct indications. And I'm sure over the next day, we're going to hear very much how and when you choose which one. But the bottom line is that both approaches are safe, but we do need to take into account the patient outcome measures and relate those to the learning curve. There's no point in rubbishing a procedure if the surgeon's only done 20 of them. Let's have a look at dural tears. These are interesting. Dural tears in spinal endoscopy relate to the surgeon's skill, training, instance, risk factors, and management. And the most interesting thing about this paper published last year is that of 64,500 lumbar endoscopies, the incidence of incidental durotomy was only 1%. And I think that's highly acceptable to anyone. So if in your own hospital, the management are saying, well, we don't need to buy endoscopy equipment, you certainly do. And this type of paper is very good supportive evidence for us. To get to spinal decompression, you do need good equipment. And for different procedures and parts of an endoscopic spinal decompression, you need small burrs, medium-sized burrs, and large burrs. And these are all produced by many companies. Some are better than others, but they are available. And you need a repertoire of burrs to undertake your decompression. Navigation. Again, the advantages are we can check the anatomical level. We can easily localize our needle. We reduce the radiation exposure. And probably most important, in time, we're going to have a system whereby the robot will be guided by the navigation system, and the surgeon will be drinking coffee in the coffee house. So what about cost effectiveness? Well, Choi produced this interesting paper in 2019, looking at 565 patients. And he did the direct costs and the qualities gained at 1 year for transforaminal endoscopic discectomy, interlaminar endoscopic discectomy, unilateral, bilateral endoscopic decompression, and compared those to microdiscectomy. And what he found was that they were all cheaper and better. You're going to hear from Christoph, I'm sure, on the techniques of lumbar endoscopic unilateral laminotomy for bilateral decompression. And I'll leave him to take you through that. But we have now developed systems and techniques which make spinal decompression for spinal stenosis so much easier over the last couple of years. But again, we need evidence. And the evidence is that for the top one, certainly our results endoscopically are adequate, an alternative to open operation. And if you now bring in biportal endoscopy and compare that to microscopic lumbar decompressive laminectomy in patients with stenosis, we have similar clinical outcomes. What's the place for spinal fusion? So now I can be completely controversial. And I want to look back to the Cochrane review that we published in the mid-2000s. And that looked at all the trials, all 8 of them, comparing instrumented fusion to a simple decompression. And the interesting thing for all you surgeons who love instrumentation is, and this hasn't changed, there are no conclusions possible about the relative effectiveness of anterior, posterior, or circumferential fusion over decompression in many instances alone. Now, we do have great instrumentation now. We can do all sorts of endoscopic decompression and fusion, but you have to ask yourself, should we be doing it? So, what's the evidence? Well, we've actually got good evidence for endoscopic fusion. But if you compare it with MIS TLIFs, no significant differences. We can say there are favorable outcomes. And we can say that if you are going to do it endoscopically, local anesthetic is probably of equivalent benefit to a general anesthetic. What we don't have is an RCT showing that endoscopic fusion is any better than an endoscopic decompression in isolation. Now, you'll take that with a pinch of salt. We'll take that with a pinch of salt. And I'll come back to that in a minute, because there is an indication in some circumstances for endoscopic fusion. We haven't even started with endoscopic disc arthroplasty, so we'll pass that on quickly. And just before we leave fusion, as I have not put the slide in, in an L4-5 spondylolisthesis, we probably have good enough evidence to decompress the spine. But I'll come back to fusion in a moment. Meanwhile, in the thoracic spine, I think there is no doubt that endoscopy is the place it should be. In our open review that we published last year, we looked at all the evidence and look at the excellent and good outcomes, 81%, a complication rate of 8%, and 21 cases used local anesthesia. Now, this compares on the right side of this slide to the complications following thoracotomy, nearly 40%, costotransversectomy, 15%, and medical and surgical complications around the 20% mark. So I don't think there's any doubt now. If I have a thoracic disc, please someone treat me with the endoscope. In the anterior cervical spine, we've got very similar results, actually. And again, we reviewed these 2 or 3 years ago, and we looked at the excellent outcomes in 90%. This is anterior cervical discectomy using CSIS or cervical vertebrae or whatever system you want to use, with a complication rate of 4%, only 2.7% revision surgery, and very similar diminution in neck disability or VAS neck scores, VAS arm scores. Compare that with ACDF. Now, if you do an ACDF, you get the same outcome measures, but you've got a 10% revision for pseudoarthrosis and a 21% revision for adjacent segment denervation in the literature. Compare it with cervical disc replacement, 6% revision surgery, 36% evidence of segment degeneration. So I would say to you that there is a good case in many instances for anterior cervical endoscopy. Let's go to the posterior side. Wu published this data some 10 years ago now from 26 articles and found that the success rate of full endoscopy compared with minimally invasive foraminotomy posteriorly had almost identical results, and came to the conclusion that endoscopy is the new standard of care with more rapid recovery. So we've got lots of nice tools now. There's no limit to the advancement. We can go around corners. We can even take the SpaceX off to load satellites. And we've now got biportal systems, which may, in some instances, give more easy results, easier access, and again, probably have a place. So what's next? Well, we need more research. And I'd like to offer you these research answers that I would like discussion with and answers to. When should we perform a discectomy? Should we do it the day that we slip a disc, or at 6 weeks, or at 6 months? We don't know. What actually is the value of a root injection? I found that it took me just as long to do a root injection as to do an endoscopic disc in the first place. When should we mobilize following a discectomy? Is it at 2 weeks? Is it at 6 weeks? Should we wear a corset? We don't know. In the degenerate spine, should we ever fuse the patient? We don't know. If we are going to fuse a patient, how much does the sagittal balance matter when the patient's hips are arthritic? Now, I'd like to just show you a couple of cases to finish. First of all, discectomy. Now, here's a very simple disc prolapse at L5S1 in a very famous surgeon. That's me. And I had agonizing pain. I couldn't lie in the scanner. I couldn't sleep. And I couldn't bring up my left great toe. So the day I had this disc prolapse, I booked a flight on EasyJet to Holland to get Menno Ippenberg to take my disc out. My son, a casualty officer, said, "Dad, you have to wait. You might get better." So I cancelled the EasyJet flight, and it took me a year before I made a spontaneous recovery and without surgery. So I'd say to you, we don't know when we should do discs. To help us, we need information. And Spine Tango has been going for a number of years, and they now have almost 500,000 patient outcomes on their database. But it's a paper-based data sheet, and it isn't particularly related to spinal endoscopy. So I commend you Spine Healthy, which is Christoph's new app from Seattle, and I hope everybody will be collecting outcome data on it. By 2040, 1 in 10 of the population will be over 65. And we can't help it. We degenerate, and I'm over 65 now, and I'm degenerating. But if my spine looks like this, do I really want a fusion with 39% complications, 19% risk of reoperation, 33% risk of secondary surgery? Hey, old people don't do well from GA. So why fuse if the patient only has isolated nerve root pain? Endoscopy will relieve your isolated root pain. You can do it under local anesthetic. Excellent long-term outcomes. And it may be the only complaint in someone with degenerate scoliosis. So in degenerate scoliosis, is an expensive fusion the right option? Just have a quick look at that patient's scans. you'll see that actually they haven't increased the lumbar lordosis enough. They've done a nice job. They've got lots of screws and they've spent lots on instrumentation. But if the patient isn't fit for a haircut, sorry, I spelled that wrong, then why not just decompress the compressed foramina? So many questions. We're going to have artificial intelligence. It's going to direct our surgery in the future. We haven't even embraced shape sensing technology, which you may wish to read about. And what is absolutely certain is that we should have a system of teaching where we can move from being a beginner in endoscopy through to competency up to the level of the master. And there are several now educational programs. I would commend Aspinia. It's accredited by the Royal College of Surgeons in Edinburgh, because we need training and programs properly accredited, supervised, and of an appropriate level of education. So what's next? Well, we're moving to the robotic arm. Fine for pedicle screws, still pretty useless actually for endoscopy, but it will come. And the bottom right picture there is of an AI system used in laparoscopy. In laparoscopy, they are now having feedback from different tissues, from blood vessels and nerves, so that we know what we're doing. So in the top left corner you'll see the parking attendant at KL Airport, totally remote operating robot. Mr. Surgeon, your days are numbered. Robotic endoscopy is the next gold standard, and it will be a very exciting time for everybody. Thank you very much.
Well, Alistair, you did not disappoint. I loved your talk. That was terrific. You know, one question I had, like, you know, one of the images, there were a couple of AI-controlled robots, and there were surgical lights up on the ceiling. Can you explain why that was?
I think that's to pick up the satellite image, because they beam it down, actually.
Oh, of course, and then they land in Edinburgh. Hey, great question for you. You mentioned that, I love that you bring up the controversy of, when is instrumentation needed? Is it needed or not? But, in terms of mechanical stability, we all have, again, mechanical pain and inability of the spinal column to protect the neural elements, as defined by Punjabi is, a fact. And, how can you, so where do we draw? I mean, I'm sure that's a gray area and a gray zone, but in the end, we have to define that border where instrumentation and fixation is necessary versus not. So what is your advice there? How should we go about studying that?
Well, as a more senior surgeon, as time has gone on, I became less and less enamored by long fusions. I think there is a place for them occasionally, but even if you took a spondylolisthesis at L4-5, which we routinely probably fuse, how many of you have actually seen an L4-5 grade 2 spondylolisthesis ever get any worse? Never. It never goes to grade 3 or grade 4. We do it because we think it will relieve pain. Does it relieve pain? I'm not sure it's the fusion that relieves the pain, because simultaneously patients are decompressed. So I think it is a gray area. In many of the long fusions, we put the patients out of sagittal balance. For neurosurgeons and orthopedic surgeons, both of us, we don't necessarily look at the whole patient. Many of them have hip arthritis, the flexion deformities of the hip. We don't get the pelvic parameters correct. So I think there is a place for fusion, but I think it's perhaps not nearly as wide a place as we currently are using it for. And you'll know the statistics in the States, how many are done per annum. It is an enormous number at vast expense.
Thank you, Alistair. It's a great talk. And I had a quick question, just kind of a global perspective. I know that the U.S. is a little bit different in terms of our healthcare system, and we all know, whether we like it or not, that a lot of the decisions are driven by reimbursement. Now, given this and the fact that the U.S. does try to push the envelope with a lot of technologies, do you think that the reimbursement issue is going to hold endoscopy back? Or do you think that the global community is just going to kind of unite and say, hey, listen, this is the way you move forward?
I think we have to just push forward. I'd agree. It does hold it back. We had terrible problems in the private sector, even in the UK, trying to get a simple endoscopy funded at the same as a microdiscectomy. That's a raging battle. The insurers are wanting to drive down costs all the time, but I know there are several anachronisms in it. In Germany, they like you to stay in the hospital after your endoscopy because that's the way they make the money. How do you square the circle? I don't know. But I think the healthcare budget is enormous and we need to keep it as low as we possibly can.
Thank you.
Right. Christoph, can you hear me?
Yes.
Yes, we can hear you. Hey, Christoph, how are you doing?
Hello there, everyone. Thank you for the invitation. Alistair, that was I really, really enjoyed your presentation. I think it would be just fair, though, for the younger surgeons to just highlight one fact, is that all of the studies that you've cited, they are usually from pioneers in this technique who have experience of thousands of surgeries. And especially in this type of conference, there is a lot of enthusiasm for the endoscopic technique, which puts a lot of pressure on the younger surgeons that I must now do this endoscopically. And I'm looking at the literature, and I can see in the literature that, you know, that surgeon XYZ can do it in 20 minutes. And now they think, you know, I must be able to do this in 20 minutes. I just think it's fair for everybody here who's maybe not yet at an experience level to understand you really need to take your time. You'll get there, but it will take time. And if you don't do that, there will be a significant risk of putting harm on your patients. And all I'm saying is really be careful, take your time. The technique is fantastic, but you will need that time to learn.
I fully agree with that. And there's a lot of data now on the learning curve, both from Seattle and elsewhere. One thing that is also a slight concern is that we lose the ability to undertake open surgery. And this is particularly apparent in abdominal surgery, where now patients come in, say, with a colonic tumor, and they have a laparoscopic removal of the tumor, and they can't do it laparoscopically, and the surgeon is unable to open the patient. And I think that we need to be absolutely sure that all our surgeons are trained in open surgery as well. So that would be my advice to anybody.
I agree. Thank you.
All right, well, thanks for that discussion. And again, Alistair, fantastic. I really enjoyed it. It's always a pleasure. So we are moving to our next talk. Our next talk is about the interlaminar